Hello, and welcome to my ophthalm teacher. We've talked about primary open angle glaucoma and primary angle closure glaucoma in our previous lectures. Now we'll be talking about secondary glaucomas, and once I've finished with the glaucomas, the pathogenesis and clinical features, we'll be talking about the medical as well as the surgical management of glaucomas in the last two lectures. So, secondary glaucomas constitute a large proportion of the glaucomas because of the incidence of ocular infections, inflammations, complicated cataract surgeries, not so much, and trauma. Undiagnosed secondary glaucoma leads to substantial loss of vision before it is identified, that is, before its etiology is identified and specific therapy is instituted. So it goes underdiagnosed and untreated. The causes may vary from region to region. As I said, it can be due to infections, inflammations, complicated surgeries, and trauma. So those causes vary. More common in predisposed eyes, for example, those with a positive history of glaucoma, and you treat it by treatment of the underlying cause. Now, secondary glaucomas can be, so obviously, as the word suggests, secondary means secondary to some other disease in the eye or some systemic disease. So, we'll be talking about the eye diseases that predispose to um, causation of secondary glaucomas. So they can be broadly divided into open angle and closed angle. So now that we know what is meant by open angle and closed angle, we can understand. Open angle is again divided into three types. Pre-trabecular, by trabecular I am referring to the trabecular meshwork. So pre-trabecular means something before the trabecular meshwork, trabecular, something in the trabecular meshwork, and post-trabecular, something beyond the trabecular meshwork. That is something in the episcleral veins or beyond that, the part where the trabecular meshwork drains. Okay, that is open angle causes. Closed angle causes may be divided into pupillary block and non-pupillary block. So we've discussed angle closure glaucoma in the previous lecture. You can go back and revise pupillary block if you need to. Sometimes there may be a mixed mechanism. For example, in inflammatory glaucomas, it can be an open angle glaucoma as well as a closed angle glaucoma. Now, so let us just understand the classification with the help of these diagrams. So on this side, this is pretrabecular obstruction, right? Figure A. This is trabecular obstruction. C is angle closure with pupillary block, this thing over here, right? And this is angle closure without pupillary block. Okay. So coming on to causes of pre-trabecular. So the trabecular, this thing over here is the trabecular. This picture is from Kansky. It's a very nicely explained diagram. Okay, so I've just picked it up from there. So this is the trabecular meshwork, right? Now pre-trabecular means the trabecular meshwork structurally is all right, at least initially. The problem is something before the trabecular meshwork. That includes neovascular glaucoma. Now, in neovascular glaucoma, there are blood vessels growing here, which sort of pull over the trabecular meshwork because of fibrosis, ice syndrome, and epithelial ingrowths. We'll be talking about each of these in the subsequent slides. So, pre-trabecular causes means that some sort of membrane or fibrotic growth is growing over the trabecular meshwork and blocking it, or pulling over the trabecular meshwork and closing the angle. So pretrabecular. Trabecular. Something is blocking the intertrabecular spaces. Okay. Here, you see this is the trabecular meshwork. Something is blocking the trabecular meshwork particularly. What can block it? Pigments, red cells, that is RBCs in case of traumatic. Ghost cells are nothing but the dead RBCs. Phacolytic, that is leaked lens proteins. Pseudoexfoliation, that is amorphous white matter. So these substances can get deposited in the TM and block it, and they constitute the trabecular causes. Next, we have the angle closure variety with pupillary block, right? Now, angle closure with pupillary block may be seen in seclusio pupillae, which is seen in chronic anterior uveitis. So basically, anything that is blocked, this is seclusio pupillae, that is 360 degrees pupillary block. Okay, seclusio pupillae because of inflammatory material seen in uveitis. So the pupil is completely, the synechia is there, There's a posterior synechia in the pupillary region. Iris is sticking to the anterior lens capsule. You see this black thing? So this is one. Phacomorphic glaucoma. Now in phacomorphic, what happens? This lens is just intumescent and swollen, and it comes forward and blocks the pupil, so the aqueous cannot escape. Capsular block syndrome. Aphakic pupillary block, I'll be talking about the mechanisms. ACIOL and subluxated lens. These are some things that are going to cause a pupillary block. Okay. Capsular block syndrome is seen in cases of pseudophakia. Okay, it is the capsule here. There is no lens. The lens, it is the capsule which is sticking to the posterior iris and blocking the forward movement of aqueous. Aphakic pupillary block, there is no lens. It is the anterior vitreous which is just coming forward and blocking the pupillary region. ACIOL, ACIOL can cause pupillary block. The ACIOL is present here in the anterior chamber. So what happens is that the pupil is actually going to stick to the posterior surface of the ACIOL over here. The lens lies here, no? So again, the aqueous cannot come forward. And of course, a subluxated lens. So that's pupillary block mechanisms. Then there is angle closure without pupillary block. Aqueous is coming out in its normal route, but some problem is happening here in the periphery. Angle is closed. Okay, so that includes the peripheral anterior synechia, secondary causes, that is uveitis, choroidal effusion, ciliary body tumor, and malignant glaucoma. So no pupillary block, but the peripheral iris is pushing something wrong in the peripheral iris. That is, closing the angle. So angle closure, right? And then there are etiologies beyond the trabecular meshwork, and those include the post-trabecular causes. So you know that the trabecular meshwork ultimately it drains via the Schlemm's canal into the episcleral aqueous veins, episcleral veins, and so on. So if there's something here, some problem in this region, then there is back pressure, right? Again, the aqueous cannot flow because of the back pressure from the veins seen in elevated episcleral venous pressure, carotid cavernous fistula, Sturge-Weber syndrome, obstruction of SVC. All these conditions are going to cause elevated episcleral pressure, leading to backflow and inhibition of aqueous outflow, right? So please just memorize the slide. It's a very easy to understand slide, and the diagram is from Kansky. So just coming on to the individual causes. Now, please bear with me for the busy slides because see this, I have just, sort of summarized the secondary causes of glaucoma. It will be easier for your exams and for your viva. For UG students, this presentation is enough, but for PG students, you need to go back and read Shield's textbook. The individual secondary glaucomas are given very elaborately in that textbook. It's a wonderful textbook. But again, you can come back to this PPT for revision. So that's why the slides may be a bit busy because I just, tried to make it very concise and tried to put each cause, try to fit it in one slide only, right? This is for revision. You have to go back and read your shields. Okay. UGs, you can just memorize all the contents of this slide. It's enough for you. So pseudoexfoliation syndrome, the commonest cause of secondary open angle glaucoma. Now, pseudoexfoliation syndrome and glaucoma are two different things. So what is pseudoexfoliation syndrome, abbreviated as PXF? It's a condition in which exfoliative material is deposited on the iris, ciliary body, zonules, and lens capsule. So you see, this is that exfoliative material, white amorphous powdery substance deposited everywhere in the anterior segment. When does pseudoexfoliative glaucoma happen? When this exfoliative material collects in the angle of the anterior chamber and obstructs the angle drainage, right? So open angle glaucoma and of the trabecular variety, usually. Clinical features consist of white flakes on anterior capsule of the lens and the edge of the iris. So see, you see two rings here. This is one ring and this is the outer ring. This is because the mid-peripheral iris keeps rubbing here, and so because of the iris chaffing on this anterior lens, this part clears off. But wherever the iris stops, that is in this region and in this region, the pigment deposits, I'm sorry, not the pigment, amorphous substance deposits in the form of a ring. So this is known as target sign or bullseye sign, right? There is one inner circle, there is one outer circle. Target sign is seen in a number of features. Okay, it's just a term used to describe this clinical appearance of a circle within a circle. Sampolese line. Now, often in these patients, you see that there is more than the normal amount of pigmentation in the trabecular meshwork, right? In the previous lecture on angle closure glaucoma, I've talked a little bit about the anatomy of the structures in an open angle, right? So please go through that. So Sampaolese line is basically an increased pigmentation, an extra line of increased pigmentation that may be seen anterior to the Schwalbe line. So in this case, the anterior most irregular line that you see is the Sampaolese line. And this is a pigmented Schwalbe line, right? And this one is a pigmented, a more than usual pigmented trabecular meshwork, right? And this is the dark structures. The next dark structure is the ciliary band, the scleral spur, the white scleral spur in between. All right. So this is a wide open angle, right? Which is heavily pigmented, and the Sampolese line is there. Krukenberg spindle. Krukenberg spindle is usually a vertical deposit of the pigment on the cornea. It is not seen in gonioscopy. It is seen as a I don't have a picture of that here. It is a vertical deposit of pigment on the cornea. That is known as a Krukenberg spindle. The shape is that of a spindle. Again, you see in this diagram the white amorphous deposits at the pupillary margin. The 5-year risk of glaucoma in cases of pseudoexfoliation syndrome is 60%, hence commonest cause of secondary open angle glaucoma, right? The next secondary glaucoma is pigment dispersion syndrome, and its related glaucoma is known as pigmentary glaucoma. Pigment dispersion syndrome is characterized by liberation of pigment granules from the posterior iris pigment epithelium and the deposition of these pigment granules throughout the anterior segment, commonly seen in young male myopes. So in these conditions, there is a peculiarity of the mid-peripheral iris to have a concave shape. So when the mid-peripheral iris has a concave shape, it tends to undergo chaffing. The posterior epithelium tends to undergo chaffing against the lens, right? Against the zonules. Now we know that the posterior epithelium of the iris is pigmented. So when the chaffing occurs, these pigments are released. So the pathogenesis, rubbing off the pigment layer of the iris against the zonules or the anterior lens due to excessive posterior bowing of the mid-peripheral iris. So the mid-peripheral iris is sort of bowed posteriorly or concave posteriorly, as a result of which it rubs against the posterior structures, that is the lens and the zonules, and pigments are released. These pigments go and block the trabecular meshwork. So this can cause both acute or chronic IOP elevation. So often acute elevation of IOP, the patient presents usually post-exercise, heavy exercise. A young male myo post-heavy exercise comes with acute IOP elevation, colored halos, corneal edema, right? That could be one of the presentations. So that is acute pigment dispersion syndrome. Sometimes because of such repeated episodes, a chronic IOP elevation may also happen. So then it is known as secondary open angle glaucoma when the associated optic disc changes are also there. Pigmentary glaucoma is the other name for it, and it is seen in 1/3 cases of pigment dispersion syndrome. What do you see here? You see this pigmented line on the cornea, right? So that is your Krukenberg spindle here. This Krukenberg spindle is also seen in pseudoexfoliation syndrome. Intermittent halos, obviously, when the pressure rises, wide open angle, Krukenberg spindle, iris transillumination defects. Now, iris transillumination defects, the posterior pigmented layer of the iris is shedding, right? So, some sort of atrophy is going on. So, when you throw light through a normal iris, the light doesn't pass through. So, iris transillumination is when the pigment epithelium is lacking, the light can pass through. And when you observe the eye in retroillumination, those areas appear red in color, right? So those are known as iris transillumination defects. Then there is a Shea stripe or Zentmeyer lines or Sampolese line. All of these are just some names consisting, and all of them consist of Patterns of pigment deposition. Okay, Shea stripe or Zentmeyer line happens on the anterior lens. Okay, usually in the equatorial region. It is nothing but pigment deposition. Sampolese line, you already know. Sampolese line is seen on gonioscopy, and Krukenberg spindle is seen on the corneal surface. Good long-term prognosis is seen in this pigment dispersion syndrome. So those are the iris transillumination defects that I'm talking about. You see, the pigment epithelium has shed off in this region so much that light can actually pass through the iris. And this is a photo taken in retroillumination. Again, this one, this heavily pigmented, this line is the Sampolese line, right? And you see how heavily pigmented, it's nearly black. That is your pigmented trabecular meshwork. Neovascular glaucoma, another very notorious variety of secondary glaucoma, commonly seen in diabetics and patients of retinal vein occlusions. So glaucoma secondary to neovascularization of the iris, known as rubeosis iridis or angle. Now the pathogenesis. Usually in PDR, that is proliferative diabetic retinopathy or retinal vein occlusions, retinal ischemia happens. We have had a lecture on diabetic retinopathy, so you understand these terms, retinal ischemia, VEGF, and neovascularization, right? If you do not, you can go back and revise those lectures, the lectures on proliferative diabetic retinopathy. So retinal ischemia stimulates the release of VEGF from the RPE. That VEGF is responsible for neovascularization of not only the posterior segment but also the iris and the angle, known as NVI or NVA respectively. Now, this neovascular tissue has a tendency to cause fibrosis. Fibrosis leads to adhesions of the peripheral iris to the cornea, leading to a pre-trabecular type of angle closure. Okay, so it pre-trabecular type of open angle. Eventually, angle closure can also happen. In early stages, a pre-trabecular sort of blockage can happen. A pre-trabecular open angle secondary glaucoma can happen. Later on, these adhesions are going to close up the angle, leading to a secondary angle closure. So usually it is the angle closure stage that is the stage at which the patient presents to you. Clinical features, you see neovascular NVI. So this is neovascular. See these fine blood vessels. So it is very important to examine the PDR patients under high magnification to look for any neovascularization on the pupillary margin. This is often a very early sign, and it is supposed to have a good prognosis if managed at this stage. Okay, so see these fine blood vessels at the pupil. This constitutes NVI. Sometimes these blood vessels can grow beyond the pupil and spread onto the surface of the iris. That is again known as NVI or rubeosis iridis. And then these vessels can also be present. This is the gonioscopic view. You see the blood vessels are there in the angle also, and that is known as NVA. NVA can happen at any stage of proliferative diabetic retinopathy or retinal vein occlusion, okay, at any stage of neovascular disease. So it is advisable to do gonioscopy in all at-risk patients. So besides NVI, NVA, you might find some aqueous cells and flare. You might find a little bit of inflammation, and of course the posterior segment signs of suggestive of PDR or retinal vein occlusion. Commonly, ischemic central retinal vein occlusion may be noted. The treatment, now as I told you, all secondary glaucomas, you have to treat the underlying cause. So the underlying cause here is neovascularization. So the treatment is anti-VEGF agents and retinal photocoagulation or pan-retinal photocoagulation, both of which we have discussed in the lectures on PDR. Additionally, if there is raised intraocular pressure, it may be managed with medical therapy or surgical therapy in the form of trabeculectomy and anti-fibroblastic agents or a glaucoma drainage device. All of these constitute surgical management of glaucoma. There will be a lecture on the surgical management of glaucoma as well. The next one is inflammatory glaucoma. Now, glaucoma secondary to intraocular inflammation, usually anterior uveitis, most commonly Fuchs uveitis and juvenile idiopathic arthritis. So, inflammatory glaucoma, in simple words, is glaucoma secondary to uveitis. And uveitis could be because of any cause, any cause. Okay, I have already uploaded lectures on intermediate and posterior uveitis. You could go through that. And of course, there is anterior uveitis also. So the pathogenesis. Now, in inflammatory glaucoma, the angle may be open or closed. Let's see how. Angle closure will happen secondary to complete posterior synechia and iris bombing. So remember seclusio pupillae? So this is basically seclusio pupillae, right? The entire pupil is stuck to the posterior, is stuck to the iris around all around 360 degrees. So this is known as seclusio pupillae. Obviously, the aqueous cannot come forward. So what happens? It accumulates here behind the iris and it pushes the iris forwards, causing iris bombay. So you see the peripheral iris is sticking to the cornea and blocking the angle. So this is secondary angle closure. Clinical feature, seclusio pupillae, iris bombay. This is iris bombay. Shallow AC, especially in the periphery, and peripheral anterior synechia. So this is the region where the synechia would have formed, and this is what the peripheral anterior synechia looks like. So initially, what happens is this iris has come forward, and because of the inflammatory cells, it has stuck to the cornea in places, and sometimes these become permanent. So this is what your tiny peripheral anterior synechia looks like. These are very tiny PAS, these PAS or PAS, as I like to call it. These PAS may be very extensive also. Okay, so this is what peripheral anterior synechia look like. Next, another mechanism is inflammatory cells and debris are present in the angle, right? As a result of which there is formation of a fibrotic membrane and that membrane pulls over and closes the angle. So here the AC would deep, but you would find extensive pass on gonioscopy. So the seclusio pupillae may not be there, but the extensive pass would be there, as a result of which angle would be closed, but there will not be any pupillary block. This will not be seen. Only the pass would be there. Okay. Or lastly, debris may be blocking the trabecular meshwork or there may be trabeculitis in which there is edema of the trabecular meshwork beams and they are swollen and so the aqueous cannot flow through, or there may be trabecular scarring. All of these can be seen in inflammation. And of course, the angle would be open. So IOP in these cases would be normal to subnormal and the angle would be open. It is the trabecular meshwork that is inflamed or blocked. So the angle is not closed. It's an open angle of the trabecular block type. Okay. Treatment, of course, you have to treat the underlying inflammation. So this is one glaucoma where steroids are indicated. This is also one glaucoma where cycloplegics may be indicated. Okay, the other glaucoma where cycloplegic and steroids are indicated would be your malignant glaucoma. Cycloplegics are indicated in malignant glaucoma. Steroids also plus minus. And what do you have to avoid? You have to avoid prostaglandin analogs and miotics in this particular. Please remember, in inflammatory glaucoma, there are certain medical treatment that you have to avoid, and cycloplegics are the treatment of choice, right? Miotics are contraindicated. If planning surgery, the eye should have been quiet for at least 3 months under steroid cover, right? So eventually, if secondary to uveitis, some cataract has had developed, or you are in need of doing a trabeculectomy, you have to make sure that the eye inflammation has been quiet for 3 months. Only then you plan the surgery. So 3 months is the deadline. Now, two, causes of uveitic glaucoma that you need to know about, and you may get UGs may get it as a short. Anybody can get it as short note or maybe asked in viva. So one is Fuchs heterochromic iridocyclitis. Here, this is a rare chronic unilateral low-grade iritis, wherein non-granulomatous uveitis is seen. Now, remember all of these points. So, it is a type of non-granulomatous uveitis. It is speculated that rubella may be responsible. It is unilateral and the uveitis is of low grade, okay, and anterior. It's an iritis, right? So, clinical features, posterior subcapsular cataract, heterochromia iris, that is different colored iris, low grade cells and flare, and stellate KPs. Mind you, there are no posterior synechia or PAS as we saw in the previous slides. Secondary glaucoma reported in 15% cases of Fuchs iridocyclitis at the time of presentation. The next entity is Posner-Schlossman syndrome, again a rare, recurrent type of anterior uveitis associated with unilateral acute raised IOP. Pathogenesis is acute trabeculitis. Possible etiologies CMV, prostaglandin E2, and this particular HLA haplotype. Clinical feature young male, unilateral mild ocular discomfort and halos in a white eye. White eye, why? Because it's a very mild type of uveitis. Open angles, but the pressures are very, very high, 40 to 50. This is very, very specific of Posner-Schlossman syndrome. That is why its another name is glaucomato-iridocyclitic crisis. Okay. Again, no posterior anterior synechia. No posterior synechia or peripheral anterior synechia. Treatment for both is topical steroids, just like the treatment of uveitic glaucoma. So you have to remember it's a low grade iritis, okay, and no PAS are seen in both of them. Apart from that, you have to remember their individual features. This one has a posterior subcapsular cataract, very, very common, and heterochromia iris and stellate capes. And this one has a quiet eye with very, very no other signs, but very high IOP and recurrent unilateral episodes. The next entity is steroid-induced glaucoma. So, a form of secondary glaucoma typically associated with the use of topical, periocular, intraocular steroids, but it can occur in any type of corticosteroid. So, what is the pathogenesis? This you must understand. Corticosteroids, how do they work? They stabilize lysosomal membranes and suppress phagocytic activity. Now, what effect this has on the eye? The lysosomal hydrolases are not released, number one, because the lysosome membranes are stabilized, and endothelial cells, which have a property of phagocytosing debris. These endothelial cells are present in the trabecular meshwork and they have a function of phagocytosis of whatever debris is there in the aqueous. So they fail to do that. As a result, the angle gets blocked with debris, and since the hydrolases are not released, glycosaminoglycans, which are present in the connective tissue everywhere, they cannot depolymerize. They have to form and they have to depolymerize. As a result of which, they keep retaining water. They are negatively charged, they retain water, you should know that. So they retain water and they cause swelling of the trabecular meshwork beams, as a result of which a trabecular meshwork edema happens and this leads to further blockage. So this is the mechanism of steroid-induced glaucoma, a very frequently asked question of Viva. Some other mechanisms. So what happens in POAG patients? Patients with primary open angle glaucoma are predisposed to the steroid-induced glaucoma because they already have increased hydrocortisol in the trabecular meshwork. So this is something that studies have found. So when there is already increased endogenous hydrocortisol, any exogenous cortisol would obviously potentiate it. That is why patients who are with primary open angle glaucoma are at a higher risk. Then inhibition of prostaglandin E and F is another function of corticosteroids. That's why they are given. So prostaglandin E and F in the eye are responsible for increased outflow. That is why we're giving prostaglandin analogs as a medical treatment of glaucoma. So obviously when these prostaglandins are inhibited, there is some adverse effect on the aqueous outflow also. So all these factors are collectively acting and causing this steroid-induced rise in IOP. 5 to 6% of normal population develops an IOP of above 31 mmHg after 4 to 6 weeks of topical corticosteroids. These people are known as steroid responders. Not all of them develop glaucoma. Some of them develop glaucoma. Who develop? Myopes, children, and those with open angle glaucoma may develop steroid-induced glaucoma earlier. So no clinical features, the eye is quiet or maybe clinical features suggestive of the disease for which you are giving steroids may be seen. Treatment, you either remove the steroid or you switch to an alternative or you switch to a less potent steroid. Now, despite stopping steroid, you should know that IOP may be raised still in the 3% of the population. The next variety is lens-induced glaucoma. So something to do with the crystalline lens or the intraocular lens. Now, this again can be of the angle closure type, and that includes your phacomorphic and phacotopic. I've shown them in orange, and this one is open angle type. So phacomorphic, the word morphic means something to do with the body of the lens, right? So a swollen intumescent lens body is going to obliterate the angle by forcing the peripheral iris against the cornea, eventually leading to extensive pars formation. See, this is a swollen intumescent lens pressing the iris against the cornea, the peripheral iris against the cornea. So that is phacomorphic glaucoma. Phacotopic, the word topic has something to do with position. So this is phacotopic. You see, the lens has dislocated forward, maybe due to trauma, into the anterior chamber, and it is completely blocking the inferior angle, right? So obviously blocking of the angle would lead to a rise in IOP. So that is what is phacotopic glaucoma, anterior subluxation or dislocation of the lens which compress the angle partially or completely. And then comes phacolytic. Phacolytic means the lens has burst because of being hypermature or because of trauma. And its proteins have been released into the anterior chamber and caused a severe inflammatory reaction. That is what the word lytic means. And because of this inflammatory reaction, there is severe inflammatory glaucoma. Again, that is a secondary glaucoma because of the lens. So treatment, lens removal. It is the lens that is the culprit. So remove the lens, right? That is the treatment of your lens-induced glaucoma. Traumatic glaucoma. That is, as the name suggests, secondary to glaucoma. So there are different mechanisms. Trauma can cause hyphema. That is a bleed in the anterior chamber. See, this is a bleed in the anterior chamber. So what happens in this case? There are RBCs clogging the trabeculum, causing a rise in IOP. What complications can happen if there is a very prolonged hyphema? It can cause corneal blood staining and optic nerve damage. Now, it is said that if the hyphema is less than half of the anterior chamber, height, it is associated with a better prognosis, milder form of glaucoma, and can be easily managed. So, what is the management? Topical steroids and atropine. If the hyphema is, full chamber hyphema or an 8-ball hyphema, that is basically a hyphema that is associated with posterior segment bleed also. Now, that one is associated with a higher IOP and poorer prognosis. When do you need to evacuate the blood? So that is known as an AC tap or paracentesis, and it is indicated in total hyphema. If IOP is persistently raised beyond 50 mmHg for a period of 2 days at least, then it is an indication for paracentesis. So that is one mechanism and its related treatment. Another mechanism is angle recession. Now, this also happens in cases of blunt trauma. So, what happens is that the ciliary body ruptures at the iris root, right? So, rupture of ciliary body between the iris root and the scleral spur due to blunt trauma, as a result of which on gonioscopy you see a widened, see it has ruptured, no, it has detached from the iris root. So the ciliary body band widens, right? More of the ciliary body band becomes visible. The black arrow is showing some part of the ciliary body, visible ciliary body band. See, it has widened over here. Why? Because it has ruptured from the iris root. So more of the ciliary body band is visible, and this is known as a widened ciliary body band, and the condition is known as angle recession, seen in cases of blunt trauma. This is relatively rare. Incidence of glaucoma is 10%, and usually it is directly proportional to the amount of the angle recession. For example, if it is recessed in 3 or more quadrants, it is more likely to cause glaucoma. And the clinical features include, of course, widened ciliary body band. You might also find other signs of trauma such as a iris sphincter tear or cataract. So that's traumatic glaucoma. Then iridocorneal endothelial syndrome, commonly seen in unilateral middle-aged females. There are three entities, okay? So basically this is a hereditary condition. Chandler syndrome. This is the most common subtype of ice syndrome, most common. Corneal endothelium has a hammered silver appearance. Late iris atrophy. Correctopia, this is correctopia. Okay, correctopia means an eccentric pupil. And milder variety of glaucoma, this is the more common and the milder variety of glaucoma. Okay, Chandler syndrome. The next one is essential iris atrophy. So correctopia, early iris atrophy, pseudopolychoria, broad-based pars. This is polychoria. Polychoria means multiple pupil. So because of the iris atrophy, the term pseudopolychoria is given. Pseudo multiple pupil. You see this and this. That's your pseudopolychoria. Broad-based pars. This is a broad-based pars. You see, there are peripheral anterior synechia and they are broad. Unlike the ones you saw in the previous slides, they were very small, sawtooth. This one is a broad base, very suggestive of essential iris atrophy. Ectropion UVA. So this is ectropion UVA, that is eversion of the posterior pigment epithelium at the pupillary margin. Normally the posterior pigmentary epithelium is not seen. So it is everted over here, okay? And severe glaucoma. So the latter two are associated with severe glaucoma. And Cogan-Rees syndrome, the third type. Now here there is a diffuse nevus that covers the anterior iris. So this is the nevus, and these you might find these iris nodules also. This is seen in Cogan-Rees syndrome. And this one might mimic an iris melanoma. And these pictures, this is broad-based pars. These pictures are the same. The last two, they show essential iris atrophy. See these iris transillumination? The existing iris has these transillumination, and here the iris is completely absent. So that is essential iris atrophy. That's your broad-based pars. Then glaucoma secondary to tumors. So what are the tumors that could affect? Usually it is the uveal tumors, or they can be secondaries from other parts of the body. Retinoblastoma, a common cause in children. So approximately 5% of eyes with tumors will develop secondary glaucoma. The pathogenesis is trabecular block by the tumor or secondary angle closure by a large ciliary body tumor. The pathogenesis is trabecular block by tumor cells or secondary angle closure by a large, you see, this is secondary angle closure, it has invaded the angle. So that's one. Then there is glaucoma secondary to epithelial ingrowth. What is this? This is a rare complication of anterior segment surgery or trauma where conjunctival or corneal epithelial cells migrate through a wound, proliferate in the anterior segment. Okay, so epithelium, some wound happened, and the epithelium of the conjunctiva or the cornea migrated inside where it shouldn't be. Now, what will it do? It will cause trabecular obstruction by growing over it in the corner. Here, do you see this fine membrane with a scalloped appearance? So this is the epithelium inside the cornea, on the posterior surface of the cornea where it shouldn't be. So what will you see? You'll see this grayish translucent membrane. You might also see pupillary distortion. What is the treatment? You have to remove the entire region, the en bloc removal of the affected cornea, sclera, iris, and ciliary body has to be carried out with the placement of a graft. Despite that, often these types of glaucoma are very, difficult to manage and require glaucoma surgeries. That's the tumor, and that's your epithelial ingrowth. Okay, the fine line with the scalloped appearance. The last one and the most important one is the malignant glaucoma, also known as ciliovitreal block or aqueous misdirection syndrome. Now understand what happens. Here, because of some abnormality, the aqueous, which normally flows this way, starts flowing backward into the vitreous and starts to increase the vitreous volume. And that is what constitutes aqueous misdirection. Instead of going anteriorly, it is directed posteriorly into the vitreous cavity. Why this happens? Because the anterior flow is blocked at some level, at the level of the ciliary body, lens, or anterior vitreous phase. That is the anterior surface of the vitreous. You know, the vitreous is a gel. It has a surface, anterior and a posterior surface. So the anterior vitreous surface may be blocking this, preventing the aqueous to be released, anteriorly. So misdirection of the aqueous into the vitreous volume increases, and as a result of which the iris lens diaphragm is pushed forward, or if there is no lens, the anterior hyaloid itself is pushed forward, leading to a secondary pupillary block, further worsening the situation. What are the risk factors? Small hyperopic eyes with angle closure. filtering surgery, that is trabeculectomy, laser adotomy, and very rarely cataract surgery, capsulotomy can also cause it. So the problem is here. Something is preventing aqueous from flowing forwards, as a result of which it is flowing backwards. Now that something can be at the level of the ciliary body, at the level of the lens, or at the level of the anterior vitreous surface, that is anterior hyaloid. Studies are still ongoing as to what exactly causes this. The clinical features include severe pain, even systemic symptoms like nausea, vomiting may be there, blur vision, AC is flat, mind you, and IOP very high, often up to 60 mmHg. Some important conditions you have to rule out: choroidal detachment, pupillary block, or suprachoroidal hemorrhage. A relative pupillary block anyway is going to be present because the iris, lens, diaphragm, everything is being pushed forward from posterior to anterior. So again, the treatment, I told you, the treatment of two types of glaucomas involve cycloplegic. One is malignant glaucoma and the other is uveitic. Now, why are cycloplegics given here? What cycloplegics do is that they relax the ciliary body, right? So if the ciliary body is rotated anteriorly, it comes back to its normal position, right? Cycloplegia, paralysis, right? So ciliary body comes back to its normal position. The zonules are straightened out and some space is created here, right? So the aqueous flow is re-established, and the iris lens diaphragm moves back and the AC deepens. So that is the role of cycloplegics. It restores the normal anatomical flow of aqueous. Osmotics reduce the vitreous volume. They include mannitol. So this volume can be decreased. That will also cause the normal anatomy to be restored. Medical therapy of glaucoma. And if all else fails, which is usually the case, we need to remove this increased vitreous by doing a vitrectomy along with the lensectomy. So that is the treatment of malignant glaucoma. Remember, flat AC, very high IOP, pain, treatment of choice, cycloplegics. If cycloplegic fail, pars plana vitrectomy. So that concludes your secondary glaucoma. Please stay tuned for medical and surgical management of glaucoma.